For anesthesiologists managing severe trauma, sepsis, or obstetric emergencies, disseminated intravascular coagulation presents one of the most lethal, rapidly evolving challenges in the operating room. Disseminated intravascular coagulation, or DIC, occurs in roughly 30 to 50% of septic patients and a quarter of major trauma cases. The condition is strictly defined by the simultaneous activation of systemic coagulation, dysregulated fibrinolysis, and profound endothelial injury. This table shows the 2025 over-DIC score from the ISTH, the International Society on Thrombosis and Hemostasis, standardizing definitions for bleeding disorders. The framework tracks a phase-based progression, identifying preclinical abnormalities and early-phase compensated states before the patient reaches decompensated over-DIC. A cumulative score of 5 or higher across parameters like platelet count, D-dimer, prothrombin time, and fibrinogen confirms the overt disease state. Because this progression is so highly prevalent in our most critically ill surgical populations, recognizing the early phase markers is a mandatory clinical reflex. Observe the physiological paradox at the core of this disorder. Widespread microthrombi rapidly form and occlude small vessels, causing severe acute organ dysfunction. Meanwhile, the rapid consumption of platelets and clotting factors leaves the patient completely unable to form effective hemostatic clots. As a result of this depletion, the patient will massively hemorrhage from surgical sites, mucosal surfaces, and venipuncture simultaneously. Anticipating this phase-based progression in the perioperative setting is the only reliable method to interrupt the cycle before the patient enters irreversible multi-organ failure. Across all etiologies, whether from crushed tissue, circulating amniotic fluid, or activated monocytes, the universal initiating event is the pathological overexpression of tissue factor. Tissue factor is a transmembrane receptor that acts as the primary cellular initiator of blood coagulation. This flowchart illustrates the resulting biochemical cascade. Tissue factor binds to factor 7A, activating the extrinsic coagulation pathway and generating a massive, unlocalized thrombin burst. This burst rapidly converts circulating fibrinogen into fibrin, creating widespread microthrombi and consuming coagulation factors far faster than hepatic synthesis can possibly replace them. Notice the left pathway here, representing the hyperfibrinolytic phenotype seen in early trauma and obstetric emergencies. Endothelial damage triggers massive release of TPA. TPA, or tissue plasminogen activator, is a protein that catalyzes the conversion of plasminogen to plasmin, causing rapid clot breakdown and catastrophic hemorrhage. Now look at the right pathway, denoting the hypofibrinolytic or shutdown phenotype, dominant in sepsis. Here, elevated levels of PAI1 suppress fibrinolysis entirely. PAI1 is plasminogen activator inhibitor 1, an endothelial protein that prevents clot breakdown. This allows microthrombi to persist and damage organs. Recognizing this phenotypic dichotomy dictates clinical survival. Interventions that reliably save lives in hyperfibrinolytic trauma patients can induce fatal thrombotic complications if mistakenly administered to a hypofibrinolytic sepsis patient. When treating severe hemorrhage, aggressive volume resuscitation using crystalloids and colloids creates a predictable dilutional coagulopathy, progressively reducing the concentration of whatever coagulation factors the patient has left. This graph tracks the depletion of multiple coagulation factors during massive hemorrhage. Fibrinogen is directly consumed in clot formation and lost to both bleeding and fluid dilution. It is the first factor to critically deplete, often falling below the critical threshold of 1.5 grams per liter before other factors show significant decline. This evolution transforms the classic lethal triad of trauma into a lethal diamond, adding hypocalcemia as a recognized major driver of mortality alongside hypothermia, acidosis, and coagulopathy. Stored blood products contain citrate, which binds to and chelates the patient's circulating ionized calcium. Up to 97% of massive transfusion patients develop hypocalcemia within 24 hours, completely disabling the activation of vitamin K-dependent clotting factors. You must proactively maintain ionized calcium levels above 1.0 millimoles per liter. Simultaneously, core temperatures dropping below 36 degrees Celsius globally impair every enzymatic coagulation reaction and drastically reduce platelet function. Acidosis, defined as a pH below 7.35, actively depletes fibrinogen and impairs thrombin generation. Crucially, administering intravenous bicarbonate to normalize the pH does not immediately restore this lost enzymatic function. Corrective factor replacement is mathematically futile unless these 4 baseline environmental parameters are actively managed and reversed through aggressive damage control resuscitation. Standard coagulation assays like prothrombin time, INR, and APTT require 45 to 60 minutes to process. In the context of dynamic consumptive coagulopathy, the patient's physiological state will have completely changed by the time you receive the results. This is a simulated ROTEM viscoelastic tracing. ROTEM stands for rotational thromboelastometry, a point-of-care whole blood test that measures the physical properties of clot formation and dissolution in real time, delivering actionable data in just 5 to 15 minutes. When the FibTem amplitude at 5 minutes drops below 8 to 10 millimeters, it indicates severe hypofibrinogenemia. FibTem is a specific ROTEM assay that isolates fibrin clot firmness by inhibiting platelets. This specific threshold dictates the immediate administration of fibrinogen concentrate or cryoprecipitate. If the XTEM clotting time is prolonged, stretching past 80 to 100 seconds, the patient has a critical coagulation factor deficiency. XTEM is the assay that evaluates the extrinsic coagulation pathway. This prolonged time requires replacement with fresh frozen plasma or prothrombin complex concentrate. Finally, if the maximum lysis on the XTEM tracing exceeds 15%, the patient is in dangerous hyperfibrinolysis, necessitating immediate antifibrinolytic therapy. Replacing blind empirical fluid boluses with these exact real-time threshold triggers is the only proven method to secure clinical hemostasis and halt the progression of DIC. Fresh frozen plasma contains relatively low concentrations of fibrinogen, roughly 2.5 grams per liter. This volume is insufficient for severe hypofibrinogenemia without causing massive fluid overload. You must use targeted delivery via cryoprecipitate or standardized fibrinogen concentrate. However, the recent 1,600-patient CRYOSTAT-2 trial definitively showed that administering cryoprecipitate empirically yields zero mortality benefit. Its use must remain strictly on demand, guided entirely by specific viscoelastic laboratory values. The required resuscitation target for fibrinogen in surgical trauma is greater than 1.5 to 2.0 grams per liter, while massive obstetric hemorrhages demand even higher targets to achieve stability. To combat hyperfibrinolysis, tranexamic acid, or TXA, is the standard intervention. The CRASH-2 and WOMAN trials established the exact proven dosage, 1 gram administered intravenously over 10 minutes, followed by a 1 gram continuous infusion over 8 hours. This horizontal timeline charts tranexamic acid administration parameters. There is a strict absolute contraindication based on this data. Administering TXA beyond 3 hours from the onset of bleeding does not help the patient. Crossing that 3-hour mark actively increases their mortality risk from bleeding. While antifibrinolytics are highly effective at saving lives in the hyperfibrinolytic phenotype, timing is the ultimate physiological determinant between patient survival and death. Using concentrated procoagulants in a consumptive state carries severe physiological risks. Prothrombin complex concentrate, or PCC, rapidly delivers factors 2, 7, 9, and 10, but its application in DIC is highly restricted. This matrix cross-references pharmacological interventions against specific clinical states. Notice the prominent warning for PCC under consumptive coagulopathy. Because DIC is characterized by rampant, unlocalized coagulation, adding PCC can fuel catastrophic microthrombosis. It must be strictly reserved for DOAC reversal, vitamin K antagonist reversal, or scenarios requiring extreme fluid restriction. DOACs are direct oral anticoagulants, which require specific factor replacement protocols to reverse. Similarly, routine use of recombinant activated factor 7, or RF7AA, is not recommended for DIC. The resultant uncontrolled thrombin burst carries an exceptionally high thrombotic risk in these patients. Unfractionated heparin also lacks proven survival benefit in sepsis-associated DIC. Because DIC rapidly depletes the body's natural antithrombin, the heparin molecule has no substrate to bind with, rendering it clinically ineffective. There are promising novel therapies on the horizon. Recombinant human thrombomodulin, or rHTM, and specific antithrombin concentrates show potential in managing sepsis-associated DIC by directly modulating the endothelial response, though they require further international validation outside of Japan. Successfully managing perioperative DIC comes down to a strict operational strategy. You must secure immediate anatomical source control, proactively correct the 4 pillars of the lethal diamond, abandon static laboratory tests in favor of dynamic viscoelastic targets, and strictly tailor your therapeutics to the specific hyper or hypofibrinolytic phenotype of the patient in front of you.